November Wandsworth CCG board meeting. Now, normally we have some signs up to tell people that we're streaming live to the nation, but we've had an office move and we think the signs might have been packed up and taken to a place where they're not streaming live to the nation. So just to remind everybody that we're all on video. So let's do the formalities of apologies. We've got apologies from Josh Potter, but we have Alison Roberts here in attendance. Thank you, Alison. Mike Lane and Sam Page. And we are missing a few people. I think there might be some transport issues. I've had a text from Wacker to say he's running late. And I don't know that Chris or Natasha. Oh, is there?
Yeah,
okay.
I think it affects 3 lines.
Okay, so that might be it. So but we are expecting Wacker, Chris and Natasha, I think, but we are quorate anyway. Declarations of interest. Anybody have anything to amend on the register or anything in addition to say? Jamie?
Yeah, I notice I've morphed into Nicky Williams, but I'm quite happy with it.
Have you? Okay, we'd better fix that. Thank you. Anything else from anyone? Okay, good. Right. I haven't got any opening remarks except to say what I know everything about camels that there is to know. I'd just like to say that. I spent the week in Oman, and the reason I'm mentioning it is because I'm having difficulty getting into Wi-Fi, and we've had a week of office moves where the IT has been a bit difficult, although I think is not as bad as it could have been. And I was in the middle of the desert, surrounded by camels, and the Wi-Fi was fantastic. So we can do this. We can do this. So let's go on to the minutes of the last meeting, which was the September meeting. So anything on accuracy, first of all? Stephen, I think you had something, yes.
Yeah, page 4, the South West London Audit Committee arrangements. Towards the end, there's a little mini paragraph on my comment. The point really wasn't welcoming centralisation and coordination per se. It was for a purpose. So I've suggested a form of words which says SH noted that there had been growing concern that the increasing degree of cross-alliance working had left a gap in the audit arrangements. He therefore welcomed the proposals as a way of mitigating this problem.
That's great. Thank you very much for that. We'll amend that.
Can we remove a doctor from my title, please? I feel like an imposter here. I don't know where this doctor is creeping in various minutes, but I'm not a doctor, so I wish I was.
We'll remove that. Thank you. And then, thank you. There's one thing I just wanted to add. On the clinical focus area, the mental health, I made some comments which are documented at the end about Black and ethnic minority community being represented, but there was, and we addressed that, but then there was another point which I think hasn't quite been captured here. So we were talking about people with dementia and the growing kind of numbers of people and the need to expand existing services, but also look at what else we needed in primary care. And I was suggesting that we looked at primary care-based services, and it wasn't necessarily, I think, although it's linked not for the mental health team to do. I don't know where this sits, whether it sits within mental health or within frailty work stream, actually, but I do think it's something that we should pick up on. We've got the primary care plus in practices who are supporting people, healthcare workers supporting people in primary care basis, but I think from a dementia point of view, that's something that's really necessary to look at. So could I have my comments reflected on that, please, and then perhaps we can take that forward. Anything else on amendments from anyone? Very good. And in actions, where's my action log gone? It came out late, didn't it? It's out of sync. Perhaps I will go. I think there were 3, weren't there? There was one with James.
2 with James and then with Fraser.
Oh, thank you, Muna. I must have misplaced it. So there was reviewing the choracy of the Finance Committee in common and looking at substitution in the terms of reference?
Yes, so we went through the terms of reference and they're just being amended, so we'll bring those back to the next governing body and I'll address those issues.
Okay, thank you. And then this was the ongoing thing about the ledger system. You just, to send the message up was because we'd taken it off our risk register and yet it hadn't really been addressed. It was just the board have seen it on there.
That's up again. So apologies, but I'll pick that up again.
Thank you. Keep making noise about that.
Yeah.
Keep Stephen happy.
It's a hard job.
Yeah, and then we were looking at Fraser amending the wording of risk. I think risk 111 isn't about 111. It was the number 111.
Yeah.
Is that right? At the local health and care plan.
I'll pick that one up. So we're reviewing a number of the strategic risks just to update them to reflect where we are with things like the local health and care plan. So the next time that comes around, we should see that some of those have been updated, and actually where we've got duplicates, we're going through the process to remove them as well.
Good. Great. Thank you very much. I think we're fine with those minutes. Natasha, welcome.
Just one thing, sorry, I said it already. Page 16 said that Wandsworth has the highest mental health. And I just thought that could be misinterpreted.
As being good.
Well, I was like, well, because it's talking about previously about, I just thought it might be easier to read as best mental health. Does that not sound strange for anyone else? Highest mental health?
Yeah, no, absolutely. I hadn't spotted that. I've lost it now. Yeah.
Yeah, sorry.
Yes. Yeah. What were we trying to say?
I think highest incidence of mental health conditions, isn't it?
Yes, I think.
Yeah.
Perhaps we could just check that with one of the mental health commissioners and just make sure we're getting that.
Can I just say,
fairly
I mean, we have
reflected.
said in South West London, if we include Croydon in that, Wandsworth isn't, because I think Croydon has the highest level of incidence. It might have it be in the Alliance, but I just think we need to be careful about what we're saying.
Exactly,
on
I just
that.
want to check the facts on
so
that,
it's not
really.
the whole of South West London,
No.
because Croydon has the highest incidence.
It might be fair to say that we've got a significant burden of mental
exactly.
ill health. Yeah.
It could be about the money, actually.
Oh,
So we
it
don't
could be
even know
about-
what it is doing
We've
now.
talked-
I
Even it's to
don't know.
do with the money, which would be more relevant.
We might need to go back and check what we actually said.
it was. Yeah.
Yeah.
Okay,
I
let's
think
check
we
with
should go
Tom.
back and check what we
Yeah.
said.
Good. Thank you very much. Okay, so just thinking of items for any other business. Nobody's flagged any to me so far. Any coming up? No. Very good. Thank you. Okay, so we'll get on to our part B then, which is the main item for today. So winter is coming, so it's very timely to be doing this and to be looking at our urgent care and winter planning. So we've got Caroline Scott here and Sean Stone. And guys, do you want to just, I think people probably know you, but introduce yourselves with your roles and then let us know what you're going to talk about. Sean.
So I'm Sean Stone, I'm the Director of Student Resilience and Trust. I will do, thank you. Across the three of us, we'll talk you through the presentation that you have today about AD performance and particularly preparations for winter. I think it's fair to say that each year that's gone past in the last 5 or 6 years, the amount of time, energy and resource that goes into winter planning increases, and likewise the amount of scrutiny that our regulators subject those plans to increases. The winter pressures that we saw last year and the plans we had in place have been subject to a huge amount of review and reflection in creating this year's plan. And I think last year, again, a huge amount of work that went into the preparation for winter, and a great deal of learning that came out of that, and a great deal of considered thought, which resulted in several review sessions back in the latter part of the summer, which has informed planning going forward. Regardless of the winter, though, we on a monthly basis monitor A&E performance, and we know that since April, as the chart at the bottom of page 25, the second slide in the pack shows, that the red line has significantly increased from where it was at the end of winter, to give a very stable performance from May to September, albeit below the 95% national target. But certainly in comparison to many other trusts in London and nationally, St George's are delivering stable performance, albeit below the 95% standard. There's been a whole host of work over the last few months looking at ways in which that performance can be increased by 2 to 3% to comfortably achieve the 95% standard. The Trust developed back in the summer a 15-point plan. Part of that plan has been delivered, and part of it, 2/3 of it, remains red or amber rated, but there was a large part of that was scheduled for delivery in late September, but the impact of those actions being delivered in late September being seen over November and December. Many systems changes, some workforce changes that have been delivered in September. We'd expect a lead-in time of a couple of months to see the impact of those. We also know that the Trust St George's have a plan to launch an increased electronic system, ED Paperlite as they call it, in November, which will free up some clinician time from administrative tasks, and it's intended to further improve patient flow and performance. And likewise, patient flow coordinators is something that will be further extended over the coming months to help support performance. Mental health delays have been a feature of both last winter and ongoing, and again we've got some further work that St George's is doing with colleagues at South West London St George's Mental Health Trust to improve performance for patients who need onward care from the Mental Health Trust. And a very successful point of care testing equipment that the Trust brought in last winter for flu is being extended and refined going into this winter, so there'll be more capacity and a more targeted approach to using that. So Sean and Caroline will come on and talk in some detail about the content and aims of the winter plan, but in terms of the overarching performance position, I think from a CCG point of view, we are assured that that performance is stable. There are some known issues that are still being addressed. The 15-point plan, which is partway through delivery, does include, from a CCG assurance point of view, all the right things to increase and stabilise performance, and in large part has delivered much of what it intends to do. But as the pressure increases and more people will seek to use St George's services over the winter plan is yet another enhancement on top of that, which seeks to, as far as possible, mitigate that demand. I'll hand over to Sean and Caroline now to take you through what that plan does and what the implications are and the objectives to that plan going forward.
Thanks, John. So the overriding message, I think, as John said, is that we're much better prepared as a system, and the slides that you've got are part of a much bigger comprehensive winter plan that covers all partners across the system. So the process has been managed through several work streams, and this started as we finished last winter. The Mercy and Wandsworth communication programme is now the most sophisticated it has been, and we'll be targeting specific patient cohorts based on the local issues that we've got, and the two areas that we're going to be focusing on are working age adults and flu jabs for the under 4s. The communications team undertook an audit in St George's ED, particularly asking working age adults why they'd attended ED, and some of the learning to come out of that was around patient education and improving the 111 process. We repeated the demand and capacity modelling, which shows analysis by month and by specialty, and that's told us that the biggest bed deficit that we're likely to have will be in January and February, and around medicine, and that ranges from about 26 to 42 beds. However, it's important to note this is a target occupancy of 92.5%, and that's the occupancy level which will allow the Trust to achieve the 4-hour standard. But there'll be times where the occupancy level will need to be higher than 92.5% to cope with the expected increase in demand. The system has come up with a response plan to mitigate that bed deficit, and that equates to around 28 beds, which we delivered through additional capacity and admission avoidance schemes. And overall, the plan is to have enough beds at times being at full occupancy, but there will be enough beds over the winter. In terms of the key risks, so there are less beds on the St George's site this winter, with around approximately 30 beds. There's also been some changes to the services and the market in both community and social care sectors. Workforce remains an issue across London, although St George's do have a workforce plan in place, and actually they benchmark quite well against other providers. As John said, there have been issues around mental health capacity, and SLAM, patients waiting for SLAM have been a particular issue, but that's improved recently around changes to commission capacity. The biggest risk month for us is February, and that's not just around acute beds, but also other system partners seeing an increase in demand around February as well. In terms of the key mitigations, so St George's and relevant system partners have made significant efficiency improvements over the course of the year since last winter. And a lot of that has been delivered through the expansion of the ambulatory emergency care pathway and improved discharge processes both internally to St George's and externally as well. So what we've seen is a reduced length of stay, and as John alluded to, we've seen an increase in performance, and St George's now is performing better this year than it was this time last year, and that's in spite of them having 30 less beds on the acute site. The trust escalation process has also improved, and a lot what was in place last winter as winter initiatives have been made business as usual, and the discharge allowance is one example of that. We've been having conversations around exploring mutual aid, both in Merton and Wandsworth and across South West London, and in particular looking at the ability to move staff around the system to better suit demand. John also alluded to the fact that the St George's point of care flu test and the ED capacity will be doubling for this winter. And there'll be a refining of the patients that will be tested for flu, and that's expected to mitigate against bed loss for flu, but also to improve performance as well. There's conversations underway to ensure that we use the £2 million of social care winter funding in the best way possible. And I think just to conclude, in terms of the winter planning process, it's just to say that this is the most comprehensive planning process that we've been through. The detailed winter plan has been signed off by the Emergency Care Delivery Board and will go to the regulators today. And I'll hand over to Caroline to present on some case studies on some pathway improvement that have been in place since last winter.
So as Sean said, I've been asked to come along just to talk through a couple of kind of case studies of things that we are doing to help improve our admission rate and improve our sort of flow through A&E. So the first one you can see there is the OPAL, so the the Older Person Assessment and Liaison Service. So we know that a high number of emergency admissions are in our older patients, and research has shown that kind of specialty input from an earlier perspective really improves not only their outcomes but also their length of stay. Our current OPAL service, so that's a team made up of senior health doctors, previously known as geriatricians, senior nurses, and linking in with the therapy team. They're currently based on the admissions unit, and they see patients who have already been admitted to hospital. They provide kind of care plans. Often these are patients they actually already know because they're well based with the community services, and sometimes they're actually able to get patients home who the medical team might have otherwise admitted to a ward. One of NHS Improvement's 2018-19 ambitions is that by the end of 2019 there'll be a provision of a kind of acute frailty service 70 hours a week, and our vision is that the OPAL's team will essentially be providing that, but to support them in doing that, what we're trying to do is bring forward their assessment so that patients aren't admitted before they're seeing the team, but so they're actually picking them up in the emergency department. Now there's some challenges around that. You can imagine it's a fairly specific team with a really specific skill set that you need, so finding the right staff can be quite difficult. Staff retention has also been slightly challenging for the team. It was set up as quite an organic, there was a recognised need for it. It was set up quite organically, so there wasn't really a clear service specification in the first place. And then they've also had some capacity challenges with their community services and the social services as well. But so there's a pilot that has commenced from September this year, looking at bringing that OPAL team into the emergency department, picking up patients earlier in their journey and ideally diverting them away from even reaching the admissions unit. And there's a sequin to support the trust in being able to deliver that pilot. And if it's successful, we'll look to roll it out. The other example to bring to you is about streaming. So streaming is the redirection of appropriate patients back to their primary care to see their own GP rather than being seen in the A&E department. And this isn't a new thing. It's been going for quite some time in St George's, but there've been quite a lot of challenges around it. Again, you can imagine it's quite clinician specific. So the person who is doing that streaming, it really depends on their ability to work with patients. There wasn't a clear process in place, so that made it more difficult for those clinicians. It was originally only adult patients who were being streamed back, and we know quite a lot of our A&E attendances are from children. There was quite a lot of variation in what that primary care access was across Merton and Wandsworth in terms of access to GP appointments. It's difficult to get patients out of A&E if you can't get them somewhere else. And it was a manual process, so it involved making a phone call to a practice, seeing if they had the appointment available, booking the patient in. So following an audit to kind of baseline what their performance had been, a protocol was developed to really support them in the process. The age range was extended, so it now includes children from 2 upwards being redirected back to primary care. Merton practice, I recognise this is the Wandsworth board, but Merton practices have been supported so that we've now got the same access across Wandsworth and Merton. And also an electronic booking system is being implemented so that rather than having to contact the practices by telephone, they're able to online access which appointments are available and book patients directly to see their own GP, providing them with essentially a better service than waiting in A&E. Thank you.
Thank you very much, guys. That's really good to hear. So much has gone into it, and I know from so I chair the Emergency Care Delivery Board, and I've kind of seen this evolving over the last few months and weeks, really. And it's an immense industry and a much more scientific approach to this than we've taken before, and it's much more comprehensive than it's been before. It really is about the whole system coming together. This is, you know, the 4-hour wait is our barometer for how the whole system is performing, really. So so I'm kind of immersed in this, so I'd be really interested to hear what other people think who aren't so immersed in it as to the approach that we've taken, and whether there are gaps, things that you think we should be doing more of. So yeah, open for comments. Carol, then Stephen.
I think this sounds great. I think it sounds really imaginative and well thought through. A couple of questions. One is, when patients are seen by the specialist team and redirected to primary care, are they able to get an appointment on the same day, or is there a gap? I mean, you know, I'm just thinking of somebody going in and then being sent back out, but without getting taken care of in any way. And I forgot what my other question was.
Oh, Katie, you wanted to answer that.
Respond to that. So in the last year, Carol, we've actually commissioned an enhanced service with primary care so that patients can actually access an appointment within 4 hours on the day when it's clinically necessary, and absolutely so the ED through their new electronic booking system do have access to those slots. The bit we're working on at the moment is getting 111 to actually start making use of those slots, as well as, again, hopefully to improve the capacity over winter.
And I think it's fair to say that the numbers of patients that would be redirected for having gone to A&E would be really small. You only do it when it's clinically appropriate to do that. There's something about the behaviour change thing of that, but fundamentally it's about patients' perception of whether they can get an appointment in general practice when they need it, because it's often because once they couldn't, that then they're always going to go to AED beyond that. And that's what we found when we did the Monday morning survey. When people went in, that's what they said is, well, I couldn't get an appointment with my GP last time, so I'm not going to, or 111 told me to go last time, so I'm going to do that again. So there's, you know, we need to make sure that you know, general practice is the first port of call for people who think they need to see a doctor rather than ED. That's where we need to do the work. Sarah.
That, because so the two things I thought was, so what we don't want to do is people think that they get a quicker a quicker appointment with their GP by going to A&E. So how do we stop? So what do we do about that? That was the first thing. And then the second question for me was, how do general practice manage that? Because they're going to be small numbers. You can't hold appointments, otherwise actually then you start to have a problem.
We do hold appointments.
So
then does that
so I suppose
hold appointments?
So I'm asking, is that causing us a problem that we're holding appointments that then we aren't using?
Katie, do you want to?
So yes, on the second point, we have a process in place with general practice. So they do hold appointments on the day up until a certain point, and I think they're then able to release those slots 2 hours before if they're still vacant, so they can obviously use those for other patients. In terms of making sure that, I suppose, patients are not using the appointments inappropriately, so there is a clinical triage process, and ED doesn't only have access to booking patients into those appointments on the day, but they also have access to appointments going forward, so they can book them into routine slots as well, depending on what's actually necessary.
It's not a problem so far.
Okay.
So I think there was a concern about patients calling 111 if they thought that would be a quicker way to get into their GP service, but we're not finding the volume of these are massive. Primary care have far more slots than are filled by patients being redirected from ED, and so it's not really a problem at the moment. Stephen, next.
Firstly, I welcome this, and I welcome the initiative. Sound excellent, and no issue with that. I was just struck by, this is really an observation more than a question, I suppose, on the second page 26, which is that sort of graph over the last year. And the more I looked at this, the more I sort of asked myself, what is the problem here? Because we talk about winter and we talk about surges. Yeah. But what struck me looking at this graph is, I can't see any winter pattern at all in terms of volume. I mean, I see the performance dip. And if anything, May seems to loom high and February low. Yeah. So it's, on the face of it, it's not obviously an obvious winter problem. And secondly, nor is it a surge in terms of which I always rather assume that year on year there was some sort of mounting, levels of people coming to the ED, and again, there's no evidence of that at all. So I'm not quite sure whether it doesn't particularly affect the actions, but it affects what is the problem we're trying to solve here. I assume that the problem is that within this relatively stable cohort that seems to be much the same, frankly, across the year and from one year to the next, hasn't changed very much. In the winter, the composition must change. I assume that must be the problem. In which case, the question is, what are the features? Why, what are the features of this? I can imagine that some possible features. They may be iller and something, but that's a different problem from a surge. And so I'm just I was left with these questions of what's the nature of this problem? Also, given that the volume is so stable and has been stable for a couple of years, a slight sort of anxiety about, are these measures going to be any more effective than the kind of not totally dissimilar measures we've had in previous years? And the particular specific issue there, I suppose, was, is there any inbuilt optimism here? And particularly, I didn't entirely understand it, but this thing about 92.5% occupancy, where it says the plan assumes that, but then it immediately goes on to say, however, that's unrealistic, or words to that effect. In which you say, well, hang on a minute, it may be a wonderful plan if all the assumptions are true. I mean, it's like Brexit. It could be wonderful if the world is wonderful, but if the world isn't wonderful, the plan isn't wonderful. So I was just left with questions in the sense of, and whether are articulating quite what the challenge is here. But having said all that, I have no real problem with the actual proposal, which does seem to be entirely sensible and good stuff.
Yeah, thank you. James, do you want to comment?
Yeah, so I think that you're probably right about the chart on 26. So because still the overwhelming number of our A&E attendances are walk-in minors in numerical terms, that graph, and also you've got a different number of days in every month as well. So that graph runs the risk of hiding the underlying driver, which is the number of patients who attend medically unwell and complex and potentially requiring admission. So, ambulance conveyed medical majors patients, and they're in numerical terms a relatively small percentage, but they do markedly increase in the middle of winter, and they are actually the driver of the pressure. If you look at A&E performance, actually your non-admitted patients, the ones who turn up and then are discharged and sent home, your performance on the A&E 4-hour standard will be often 98 or 99% on those patients. What actually drives your ability to hit the 95% standard will be your ability to deliver an admission within 4 hours for the patients who go on to be admitted in the hospital. So actually, if you'll see a significant differential, and that doesn't come through from that graph.
Yeah, that's the problem.
Yeah,
it's not actually.
Not actually. I mean, you can have days, and the other thing that this doesn't highlight is you will have days where the total number of attendances just overwhelms the department. So if you have a combination of a lot of sick people who need admission, and then a lot of attendances for other stuff as well, that can overwhelm the department. So both of those things, in a sense, don't really come out from that particular graph. I think in terms of the 92.5%, I think the point with this is, if you are in a position that you can't shoot for 92.5%, then the risk of you having a particular day where your occupancy actually goes over 100 and you're just backing up back into the A&E department for a significant period of time goes up. If you try and plan for 92.5, if your plan goes wrong, then you've probably given yourself more headroom to be able to manage the particularly difficult days. If you're planning for 95 or 97, which is where you might actually end up, then you'll probably have a day where you kind of in theoretical terms go over 100. So it's about trying to give yourself some planning contingency. Ideally, the evidence tells us that care is better when occupancy is between 90 and 92. That's about as effective as a hospital ought to be. The reality of NHS hospitals over winter over the last few years is that there will be at least some days and some weeks where occupancy is significantly higher, but we will try and plan for a different level to give ourselves that headroom.
Good, all right.
Yes, I could see why all those sort of issues. It's a question of articulating what the issues, and I think it's about peaks, isn't it? That's what you're really talking about. It's about peaks rather than caseload and the composition and the changing composition. And I think therefore that's probably what we should be monitoring in a sense, rather than the averages matter, but.
Yeah, and what we haven't brought here is some of the system dashboards. So there's a quite rich system dashboard that the ECDB looks at, which basically looks at all those different flows. So it looks at your admitted versus your non-admitted flow. It says, what's the peak levels, what's the comparison with last year, and that gives you a much richer picture at an operational level of what's really driving poor performance, and that's the data that the ECDB looks at on a regular basis.
Okay, I've got a few people stacked up. Natasha, Zoe, Chris. Natasha.
Thanks. I've got a couple of questions. First, I think it's great that you're doing this more scientific approach, and that kind of focus on prevention with the OPAL team. I just wondered how it was assessed that was the kind of number one, if you like, focus to look at. I know that obviously the numbers of patients who are frail, but I just wondered what other conditions might be there which could eventually be preventative, and how we're measuring that over a year, because with the seasonality, particularly of flu and actually epidemiology going up and down every year, I guess that in any one year a different disease entity which is exacerbated could be the primary problem when there is a peak of admitted patients. That's not too long a question. And the second part of that is then what flexibility is there in the system, or you mentioned it, but how, for the unpredictable nature? I remember last year there was a really poor weather which affected transport, and it was at the same time as flu and lots of respiratory exacerbations. So I just wondered a bit more detail about that if you've had a chance to look at it. And I've got one more comment afterwards. Thank you. Good excuse.
So in terms of the first bit and why OPAL and the kind of the frail elderly, so there's been a lot of evidence nationally about why that's an area that you need to focus on, and in terms of the resource required, not just in the ED, but also in terms of bed base as well. It's seen that that's a population that really can have a big impact. And it's also like a national transformational ask as well. So that's essentially why we're trying to focus on that population first, if you like. What's the second question?
It was about the other conditions that relate to that. For example, respiratory infections, which can massively increase, which may be actually not in your frail elderly, but they actually, for example, patients with COPD who massively then increase. There's a big spike in those admissions. I just wondered what other conditions we were looking at as across the system that we could help to prevent.
And I think that probably goes on to the point about the kind of the wider system input. So in terms of the acute pathway, that the frail elderly is one that we've been focused on. In terms of some of the other conditions, I think other system partners are focusing on other areas. So essentially, so the frail elderly is what we're trying to tackle at the front door.
Yeah.
But kind of social care community providers are focusing on other areas in terms of the back end of the hospital and trying to pull out patients earlier. And an example of that is, so there's now what we're calling the Transfer of Care Bureau pilot, which is basically the way that the system operates differently. So previously we've had MDT work in, say, 1 hour daily meetings with a wider MDT. The approach they're trying to take now with the Transfer of Care Bureau pilot is about having people based there all the time. So having like a wider MDT based there all the time, working together on a day in, day out basis, as opposed to just coming together kind of once a day, and they're trying to tackle different areas.
Okay, so next year, will you have a greater picture of kind of like which disease entities and which problems really cause problems over the year? Will that be built on year, so we can see that every kind of 3 years that X is a problem or Y? You might know this better than these guys.
So I mean, I do think we ought to look at that. I think you're quite right, but I think there's one obvious area that we probably isn't reflected in this, and I noticed when I kind of read the winter plan yesterday, the whole of it, it's not really reflected in there, which is about COPD. And we used to have a respiratory clinical reference group, and it was very focused on COPD and asthma. And we don't have that anymore because we put in place pulmonary rehab. We had lots of medicines management input into improving how these patients were managed in primary care, and we had respiratory nurses in the community. And we don't have that work stream anymore, so there's really no oversight of how all of that pathway is working, and I think it may be a gap. Now, it might not be, but I do think we ought to look to see whether it is or not. So I wonder if that is something that we can think about, because people should be getting their pulmonary rehab now, and they should be getting their rescue packs now, before winter starts. And they might be, but there's nobody focused on that at the moment.
It was a massive problem last year in Georgia.
So I wonder if we could take that away and perhaps do something with that.
Related to this guy. So one of the things we might want to look at is the differential uptake of flu vaccination. And it's not just the over 65s, but people with underlying conditions.
Yeah.
I know from audits several years back, the uptake from people with long-term conditions and kidney disease and stuff was low compared to the general population. Yeah. And this is a possible preventative measure.
And this is very easy data to get because
exactly.
it's in our quality and outcomes framework. So yeah, we could look at that. Okay, was you had another comment, Natasha?
It was just about, it's really nice to hear the coalescing of kind of like the system, kind of thinking about if we're moving people out of ED, what effect does that have on GP practices, and what effect does 111 have as well? And I just wondered if we might want to look at some sort of joined up digital solution for directing patients to where there's capacity that suits their need. There are solutions out there, but I think it's probably a bit late for this year. But just as just to plant the seed, perhaps.
Yeah. Okay. Thank you, Zoe.
I think it follows on really. So what I thought was great about the plan was it acknowledged that it was a system. It is a system issue, and it starts with the patient, and the fact that in the plan it's acknowledged that behavioural change for patients in certain age groups is really important. And it'd be interesting to hear a bit more about that and what methods you're using to try and help patients decide when they're ill where they need to go. Because as Nicola was saying, we want people to be thinking of primary care first, but also we want them to be thinking about how they might manage themselves and how they might use other resources in the community to help to support them when they're unwell, because as Natasha was saying, we also need to think about the demand on primary care. The same pressures affect primary care as affect secondary care, so we have problems with capacity in the winter with staff sickness and increased demand, and so I think when we're supporting the system, we need to support patients to make the right choices, and sometimes the right choice is actually to manage themselves or use other community resources. And I thought that was.
Can I come back a little bit?
Yeah, sure.
So the communications team across South West London, I know we've got the focus locally, so can I just say that there are different focuses locally, but we're working to the same kind of methodology. So looking very much at things like social media. So some of the things that have been explained to me, which I thought were really fantastic, were when, so say a mother goes online and they go on their Facebook or something and they look up something around their sick child, what it will do is work out where they are. It will actually have one of those pop-ups that recommends, you can ring, you can access an urgent treatment centre, or you can access this, or you can ring your GP, this is the number. Even to the point where they were saying that if someone is walking past a pharmacy to get to an A&E department, they can actually have a pop-up where they're looking something up that says, did you know this pharmacy is open 24 hours a day and you can go and access this? So we're trying to be a lot more focused. It's the first time we've done it in this way, so I think we'll have to, and Charlotte is very keen on that, evaluate what we do to make sure that the actions that we have taken have really made a difference. And I'm sure we won't get it totally right, but I think it's going to be a lot better than anything that we've had in the past. And actually by identifying also the two groups and there are different groups across South West London of patients that we want to target for certain things, we're trying to do that in a way that makes sense as well around the local need. So I'm sure that, and I'm sure Charlotte can wax lyrical about the detail around that, but I think it is a step change for us in how we do things around communications and engagement, but we will have to make sure we check out that it has actually worked or made a difference.
Can I just I think that's all really good, and I've heard about it and seen how it's going to work, but I think it's very good, but it's not completely going to solve the problem, because a lot of this group who are turning up are frail and elderly, and they're not on social media. So one simple thing that I think would really help, and a lot of this is patient education, is a flow chart, a small flow chart that says, what to do, because there have been changes, who you were meant to ring, how things happen. Would be cheap to do, but in our various networks of patient groups, we've got dozens that deal with this population, and something simple to hand out that somebody could spend 10 minutes explaining and the people go home with it would really help.
So can I come back a little bit on that? So one is that we are looking at champions, so people within the system that actually talk to people about the alternatives, and we're trying to do that a lot more widely with staff. So as well as doing things like social media, we are looking at that. I'm not sure about the handout, but what we will do is feed that back to the comms team. They're using it as an evidence base. So what they're doing is they're going out and saying, what do we know actually works? And they're trying to use that rather than just because otherwise we can just do so much and we just don't know what the impact of that is. So we will take it back and ask the question, but definitely the work around supporting people on a face-to-face basis. We're trying to make sure all staff, and we're even looking at champions within our own staff structure and saying, can we have winter champions that actually go out and talk to people, because it's people in the community that actually can advise, and it's often those are the people that people go to first. So how do we make sure that happens?
So I think there's kind of just pulling a bit of this together. We sort of talked about one aspect of it, but actually it's massive really in terms of the culture that we need to create amongst people, being able to understand how to self-care, and if they can't, then where they go to get help. And you could have we need a huge menu of approaches that we're going to do to try and create that behaviour change in people, and social media is clearly one of them. Giving people information, making sure they have got good access to the services. Like if you make the easiest thing to do the thing that you want the patient to do, then that's kind of important. So the social prescribing thing all comes into this as well, doesn't it? So to reduce people's needs, and then you need to look at the individual communities of people who are used to accessing services in quite different ways, and it needs to be very kind of community and culturally sensitive across. So this is immensely complex, so let's not try and fix it here, but I do think it's a really important part of the system. We can put all this in place, but if we don't help people use it right, then we're going to get surges in the wrong place at the wrong time. So we thank you for that point. Chris.
Just going back to the question of what the data is telling us and the stability of the demand in numbers at least. The waiting time is a function of demand and supply, i.e. capacity. have we modelled this data, which is showing us the attendances, with those influences on the ability of the emergency department to deal with this? I have in mind, for instance, sickness levels or other capacity problems, because the received wisdom, I think, about the winter problem is that there's a surge in demand. And I think what Stephen is quite rightly saying is the data doesn't support that of itself. I take James's point that there are periods when we may have peaks in demand, but surely there must be influences on the capacity of the department to respond to whatever demand comes to it. Have we got that data, and have we modelled that data against this information?
Yeah. John.
We certainly do have that. I mean, I perhaps should have set out at the beginning. So we've got the monthly position, but absolutely a bad Monday, which completely knocks out of balance demand and capacity, can take several days to recover. But we know that some of the problems earlier in the summer, when the weather was warm, but we were still seeing high levels of activity, some of the problems there were due to the rota fill with some locums not being available and some staff sickness. So absolutely we will monitor, and we do monitor in some detail, the workforce available. And critically, a piece of work that George has been doing for the last 2 or 3 months now is looking at the effectiveness by shift. So they look at the senior leadership of that team and are doing a lot of comparison work now to say a shift received X number of attendances and admissions during their period operating the ED, and what performance do they deliver compared to the next shift and the shift after. So they're now looking at the differential between the different leaderships of the shifts, but absolutely, as increased sickness occurs with the staff group as well as the general population over the winter, that is something we look at with George's.
Can I come in on the and also I think so. James is right about the kind of the peaks in demand and what the demand capacity and as it's based on is you're right, is the averages. What we haven't brought here today, but is in the more detailed system plan, is both the St George's internal escalation process and the wider system process as well. So when and it's actually happened this morning. So St George's gone into black this morning. It basically changes the whole behavioural culture of the trust. So people act and behave very differently. So with say St George's being on black today, it basically means that everybody then goes onto the shop floor. So kind of all things like training are cancelled. They start to look at the volume of elective activity and whether that can be done differently. They start to bring forward ward rounds, ball rounds. It just changes the whole culture. So in terms of there will be spikes in demand, both St George's themselves and the wider system change the way they operate. So for example, social care will be on site today much earlier in the day than what they would have been previously. So everybody kind of responds and acts differently to deal with that demand.
Very good. I've got Nikki and then Julie. Nikki.
Sean's just answered.
Oh, thank you. Thank you. Nikki.
I just wanted to add something in, just probably it's been slightly covered, but just as a point around that in our variation visits that we did to general practice, one of the things we did do is speak to general practice about COPD and the fact that could you review those patients now, make sure they have their flu jabs, make sure they've got their rescue packs, don't leave their 6 monthly reviews till after the winter's finished, do it nice and early and get it done. The other bit we've touched on is also the fact that if you ask members of practice staff, but other people who actually work in the system, where do you go? Some people might even be confused even if they work in the system. Yeah. So we've also an ask to general practice to make sure their staff are aware what they're doing with directing people.
Yeah, good. Okay, thank you. Any other comments from anyone? No, Jamie.
Thank you. This is really reassuring for the public that the plans are really first class. And I realise this paper is all about demand, capacity and disposal, but I'm just making a plea not to lose sight of quality in emergency department care. Just a quick story. I was admitted to a ward in St George's earlier this year. And when I was discharged, I had to sit down with the ward laptop and go through a questionnaire about my care. And basically it was friends, family and friends plus. But it gave me a chance to comment on the care and also suggest improvements. Also this year I spent 3 hours in emergency departments, and I was just discharged. There was no attempt to comment on quality or suggest improvements. So I thought that was quite interesting. So just let's keep an eye on quality.
Sean's writing it down. Very good. Yeah, thank you. Very good point.
We do struggle to get people to do the friends and family in A&E because it tends to be not the most appropriate time to ask someone how their stay is, because they're there because it's generally an acute episode. But we do look at the other friends and family information that we get back from when you then go on to a ward if you are admitted, and we do look at that in quite a lot of detail at the CQRGs. But it's a good point because the numbers for A&E are quite low for friends and family. We will look at that with St George's because they still should be actively asking people or have something in the department which shows that you can do that. Sometimes it's just a standalone unit, but we do need to still ask.
Thank you.
Stephen.
It was just a question. Obviously, George's has struggled with this for a long time, and these actions are very good. There are other hospitals which have been achieving this target. I think from memory on the performance stuff, isn't Chelsea Westminster, for example, consistently pretty well achieving this. So I assume that in all this, people are looking at, what is it that, what's the difference, as it were? Why, have they found, is it some magic pill? Is it just lots and lots of something else? Are they operating at a higher level of capacity, as it were? What would, this is not an insoluble problem. I'd be interested to know, what others are doing that we.
I mean, you're right. It's hugely multifactorial. There's never one factor. And if you look at A&Es that are achieving, there will be a combination of the seniority and consistency of A&E staffing, how the mix of patients that they're seeing, how their bed base operates, and I think most importantly, and one of the things that St George's has significantly improved going into this winter is the speed of recovery from a poor day. Because anybody can have a day where basically demand exceeds capacity and that impacts on performance, but a lot of it is about how long it then takes you to recover the position and get back to sustainable demand and capacity and high performance and kind of get out of the crisis mode. And certainly working with A&Es that have been consistently performing, what you notice is that they do sort of clear the position within the next 24 hours and then they restabilise. I think that's something where St George's have become markedly better, and I also think it's something over the last 12 months where you have seen the health and social care system outside of hospital get better at mobilising to support St George's rapidly, and in a way, we don't wait for a Friday 3 p.m. crisis now. We anticipate the crisis on a Thursday morning, and we start to mobilise knowing that it's coming over the hill, so we're sort of slightly more in place. So it is multifactorial. I would say that in-hospital and system response to anticipate and recover is probably the most important thing, because in terms of long-term performance, that's how you keep it sustainable. You will have the odd day, I think always, every single A&E in London has the odd day where it isn't able to sustain performance because of demand.
Okay, and just so final comment from me is on our care home strategy, which I think we haven't kind of hugely talked about because it's still being devised, but I think there's a significant cohort of patients who probably are best not managed in ED, and the care home strategy needs to address and hopefully will address some of how those patients are cared for in an alternative way. So I think we're bringing the care home strategy here at some point, so it'll be interesting to look at how that will contribute to improvements in patient pathway more than anything else, I think, but also in ED performance. Good. Okay. Shall we round up then? So our job really was to note the contents of the paper and discuss it, but confirm that the approach really is fit for purpose. And I think you've heard very much that people believe that is the case. So thank you very much for the work that you've all done on this. I know it's immense and it's still ongoing really. And this is just a plan now. It's the delivery, isn't it, really? Yeah, really good work. I think we're in as good a place as we could be at this point in time. So plan goes in today, Sean, doesn't it? And we'll hope that will be signed off so that we can get on with the next bit. John and Sean, Caroline, thank you very much indeed. Thank you for coming. Okie dokie. So we've got executive report. James, do you want to comment on this?
I'll take the report as read. I think probably the only bit that I would particularly highlight is in relation to, obviously we talk about the design event here. I think that for me what's probably more important than the specific event itself, which is later this month, is actually the fact that the Wandsworth Transformation Group is now beginning to really pick up a little bit of pace, and we will bring a formal update back to a future governing body, I think, with some of the outputs of the event this month. But we've got a provider co-chair for the group now, who is James Benton, who's the Chief Operating Officer of Central London Community Healthcare, and that's really important because it means that we've got that joint provider and health and local government commissioner discussion going on that says basically what are the areas beyond our individual organisational plans where working together will produce a different outcome for local residents. And we've also got the voluntary sector representation of that on that group as well. So I think it's really positive. We're looking at really trying to quite tightly define what the work programme is. So if you recall, the Health and Wellbeing Board set a number of draft priorities for the local health and care plan earlier this year. Part of the event in November is to confirm those priorities, but also look at what some of the improvement opportunities are underneath them. But what we really want to do is make sure that we don't sort of set up another meeting where just kind of a bit of talking happens, but we actually have quite focused pieces of work that say, well, you know, for example, around children's and young people's mental health, a number of organisations are doing pieces of work, but what is the benefit of us working together in a more joined up way? And most importantly, how do we need to change some of our systems in terms of how commissioners work together and also how providers work together in order to sort of break down some of the traditional barriers between organisations and really multiply the value of that joint working. So I think that's a real step forward. I think the practical implication for this board is that when we think about further opportunities to develop the MCP model, we've got the opportunity through that Wandsworth Transformation Group to really involve a very wide range of providers in the borough in saying, well, you know, it's worked really well around the work that we've done around adult community services, around some of the other services in the current MCP contract. How do we work differently with you to extend the model? And in particular, how do we get mental health and acute services beginning to be part of that MCP model? So we've got a really useful forum to have that discussion and develop some well-formed ideas to bring back for approval by the board. Apart from that, I was happy to take the report as read and take any questions.
So, James, I just wanted to ask you about the Connecting Your Care in South West London.
Yeah.
So when I read this, I thought, gosh, that's really flying at 20,000 feet, really, in terms of the detail there. Do we need to do something on this so that people understand a bit more about it? Just a question, really. I don't know what board members thought when they read it.
So I think the formal business case, which I think is interoperability phase 2, which is the formal business case that sits underneath this, will come to a finance committee in common. Is that right? In December. So perhaps if the finance CIC have a look at it and say what would be useful for boards to see following that, that might probably be the best way to do it.
Yeah. Okay, Katie.
It was just to reflect on that actually the team leading this project are out and about in the borough talking to lots and lots of patient groups about it at the moment. And I think in general the feedback has been that actually patients thought this already happened. So whilst it's obviously important to talk to them about it, I think they think we're more joined up than we actually are.
Yeah.
Can I suggest, because I think it's more than the financial impacts, I think it is just a really good understanding. So I wonder if we, regardless, actually bring something probably across South West London to governing body around the detail of what it means and how it's going to work, just for information, so people have that. So we ask the teams to do that.
I think it's important because, you know, we've got responsibilities as custodians of data and to make sure that people understand what their data is being used for and that all the governance is right around it, but also just that strategically it's going in the right direction. I think the board should have oversight of it. I think it'll be really good, and it's an interesting area for us to look at as well. Good. Okay, James, thank you for that. So, John, you're on again. Performance report.
Thank you. I'll take the overall report as read, and I'll call out some key highlights. Then happy to answer questions about any parts of the report. In terms of the highlights then, so A&E we talked about at length in the earlier item, but aside from the winter pressures and the winter planning, myself and my team continue to look at the day-to-day position in terms of some of the things I mentioned in response to Chris's question around the shift leadership, specialty response, and particularly for those patients who are being admitted, the performance of the ED to have those patients reach a bed within the 4-hour period to stop the A&E clock. I think they're the ongoing concerns we have. The 15-point plan that the Trust have had now for a number of months do address all of those concerns, but a number of those are yet to be fully delivered, although, as I said earlier, a number of the actions, the outputs of those were landed in September, but we're still waiting to see the impact of those. In terms of the Trust's RTT position, we know that for a long period of time the Trust haven't reported nationally. They are now on the cusp of having everything in place to begin their final application, to begin reporting again after a period of data exclusion. The next key milestone is a third-party review of their systems and processes. This is an external review that the CCG is in the process of commissioning in partnership with the Trust, and within the next week or so the procurement of the third party to come and do that will be concluded. That will focus on a number of things. It will look in forensic detail at the systems and processes now in place to ensure that St George's can not only produce the patient tracking lists and have good governance around that, but they can do it on an ongoing sustainable basis. So the report that we'll receive as an output of that evaluation will look not just at a point in time, but try and give us a rounded view about the extent to which these processes can be replicated on a monthly basis to ensure sound operational processes and the highest degree of data quality scrutiny, and also that any, in terms of workforce, that any part of the St George's workforce that touches RTT 18-week pathways are fully trained and cognizant of what they need to do to stop errors being made, which then require a validation team to address. You risk creating a scheme for full employment if you end up with as many errors being taken off the PTL as are being put on. So much of this work is making sure that the PTL, the hygiene of the PTL as it's termed, remains as clean as possible, so that we have a minimal validation need, that trusts who are in recurrent reporting, who haven't endured the problems that St George's have, they have very small validation teams, and we need to get to that at the earliest opportunity. Shadow reporting took place for the first time in the month of October. We're yet to see the output of that, but that was St George's, obviously not for an external audience, but for their own, again, for their own systems and processes, running a full RTT shadow report from October onwards. So we'll work with the Trust on that later this week to see what that was showing. And there continues, as the report sets out, the joint referral unit with Croydon and Kingston, which is looking at offering patients the chance to move to different sites to have their treatment sooner. There are a couple of changes in the report this month. We've included a section on activity. NHS England are keen that all CCGs include some detail on their activity position. So at the beginning of the year in the operating plan process, we make a number of predictions about the number of patients we expect to see as GP referrals, other referrals, people having first outpatient attendances, etc. And then over the course of the year, we track both financially and in terms of activity, the extent to which those predictions meet the plan that we set. The paper sets out some details where we've got some concerns, but broadly we look at real increases, so where we have seen a genuine increase in activity and what we can do to mitigate that, but also we're looking at any counting and coding changes which aren't giving us a like-for-like comparison, or any data quality issues where the data set is in some way erroneous, and trying to filter those off before we try and solve any problems which possibly don't exist in real terms. And some of that links back to the practice variation work, some of the work with GPs, particularly on the referral element of that, if there are genuine increases, to understand what's driving those and what, if anything, we can do about it. Finally, I'll just pick up the IAP position. So Wandsworth IAPS ostensibly is in a strong position. We're looking at some further recovery to the rate at which patients are recovering from that service. But that's not a major concern at the moment. And also the 4 practices in Wandsworth now that are providing IAPS services directly from the practice, we're in the final stages of implementing a software system which much more accurately tracks the activity those practices are undertaking compared to the legacy systems, and will help with some of our onward reporting to NHS England. I'll stop there for any questions.
We're well, I think, acquainted with the issues around RTT reporting and data problems at St George's. But in a sense, although this isn't directly our business, is it not at least plausible that some of the adjacent hospitals have had similar, or at least not dissimilar, problems with some of their data? In other words, is the South West London RTT waiting list data robust? I'm looking in particular at the chart on page 80 of your report.
Let me just get to page 80 and I'll respond.
We're being provided here with the whole of the South West London situation, which I understand why.
79.
79, it's 80 on mine, sorry.
So I think the issues at George's are very well known, have been subject to previous third-party scrutiny. I don't think the issues at George's, which principally relate to the way in which the patient administration system was deployed several years ago, I think are unique to George's, and the solution to those have been entirely bespoke to St George's. Are there particular trusts, Chris, that you're questioning?
No, it's just that the point that was made by you a moment ago was a certain amount of sharing of information across hospitals to give patients the chance to switch hospitals for treatment. The question is the data on which those decisions may be made robust?
So I think there's 2 points here. So let me try and come in and respond to both of them. So the first is that the South West London Trusts have instituted something called a joint referral unit, and the purpose of the joint referral unit is to support the hospital, is to support St George's, particularly with elective inpatients, so people waiting for inpatient surgery, to move to other trusts where they've got the capacity. Now, basically what's happened is that the other trusts have said these are the areas where we are sure that we have some surplus capacity that we can contribute, and then on that basis the joint referral unit, which is actually being run by Croydon, has gone into and said, well, look, St George's, these are the areas you can take. So there's been a really detailed piece of work to align the areas where other trusts have capacity with the areas where George's has surplus demand. I think the second piece is about the overall reliability of data quality in other organisations, and we have seen some, in terms of the referral numbers, some things in particular in Croydon that we think are data issues at the start of the year, but NHS Improvement has actually been doing some work to ask all of the trusts to respond to some of the data quality metrics that are very similar to some of the ones that we're looking at for St George's in terms of their return to reporting. That was a couple of months ago, and as NHS England have not flagged, I think, to anyone in the system that there are any significant concerns around the other South West London providers. So I think that with the information available to the board, it's reasonable to rely on the metrics coming from other providers.
To add what a positive thing the joint referral unit is. Nobody else across London is doing anything like this around a collaborative working between the acute providers. And what it is, it actually not only is about the providers working together, but we've tried to offer the opportunity for patients to move before, and they often don't take that up. But the referral unit actually contacts the patient direct, talks to them, explains how they can get to the other provider, how long they'll have to wait, a lot more information, and they've been much more successful in enabling people to get their elective procedure earlier. So I think it's a really positive thing. I think we need to think for South West London about, can we make better use of that and wider use of that going forwards, because now that is in place, there may be other opportunities around choice that we can start to offer where people are waiting a long time. So we have a specific issue with George's at the moment, but it might be that we start to think about that differently across South West London in the future.
Carol.
I see that just over half of the patients who needed to be clinically reviewed have been now reviewed. I think the deadline or the target date is December. Do we have any indication of what is the outcome of those reviews? Has there been any harm?
In terms of the RTT patient harm reviews,
The
I'll defer to...
unfinished episodes, I think, is the one.
Sorry. Okay, in which case I won't defer to Julie. The rate of harm that is being seen from those reviews is relatively small. I think the bigger consideration is the lessons learned from a number of inadequate administrative processes that have left people in an uncertain position where they, in many cases, have completed their episode of care at St George's, but that final link has broken and they haven't been informed, and in many cases their GP hasn't been informed. We've done an initial thematic summary of the principal issues, and at the later this month, at the Elective Care Recovery Committee with St George's, we're presenting those initial findings. I can speak with certainty for Merton and Wandsworth that the reviews are on schedule. I need to check for others, but I think broadly they are on schedule. And once concluded, I think the key thing is, although we expect to see relatively low levels of harm, that we have as part of this return to reporting, so it obviously links in as part of the systems and processes, that all those lessons learned are addressed.
Yeah, thank you. John, can I just ask you about, on page 78, the total elective admissions? So overall elective admissions slightly higher than the operating plan, but the inpatient elective work is much lower than the operating plan, and it's citing the ECI initiative as contributing to that. But I think the day case argument is much more compelling, but the ECI, I was just a bit surprised. The ECI, I didn't know it would have kind of kicked in by now. Is it in terms of that bit? Okay, that's good.
So we just on on the ECI it kicked in, and in fact, I think we had a 3 million saving at the end of last financial year. Is that right, on the ECIs alone? So it kicked in quite some time ago. So we should be getting full year effect coming through now.
Okay, and so, but the other thing I just thought is, so wouldn't you have expected, given there are still people who haven't been seen within 18 weeks, and there is still kind of a load of work, that you would keep the numbers up, that they would have filled those places that have been moved to day case or not done because of ECI, that actually operationally George's would still have been getting people through, because isn't that what we expected to happen, is that that they would still do the same number of procedures. So why is that? Is that intentional? Is it poor operational management? Is it theatre capacity? Why do you think that might be? I'm not just looking at you, just generally, do people understand this?
So I think this slide gives us a summary of a South West London position. The short answer is I don't know all the factors behind that, but others may offer a few.
I don't want us to give let's go away and look at it. So I'm going to make I can make a lot of assumptions here that they actually are, but let's go away and have a look at the data.
We'll check whether our elective inpatient within that is actually down, because it may well be that ours isn't. I think the other thing that you would need to look at is the mismatch between the specialties where there's a remaining backlog and the specialties where we've seen an impact from ECI. So the main impact from ECI tends to be spinal and orthopaedics, but actually a lot of our remaining backlog is in ENT and general surgery.
So I think this supposition is correct. I think it probably is where it can be that's happening.
Yeah, okay, that's fine, thank you. Good, okay, anybody else have any questions on all of that? Stephen?
Just a general point, really. I welcome the fact that we're getting more information about volumes, because I think we've always been weak on that. And I don't, what I was just wondering was whether we could, looking at the next, when we next iterate these reports, do more to bring the volume information into the performance areas, particularly where we've got problems. In other words, I mean, going back to the earlier conversation, where we've got a problem, is it a volume problem or is it something else? And we actually don't often answer that, and it again frames what is the issue. So I think there's something about taking the particular steer and sort of bringing it then to the mainstream, so you don't have to sort of dodge back and forth.
So I know that the guys do a huge amount of work, and we do at the executive quite a lot of discussion around individual lines and what they mean. So I think what we probably need to think through is what's helpful at governing body level that is going to help you get the assurance that you need in order for us to move forward. So I think it's important we do see activity. I think let's maybe through the directors of commissioning group start to think about how do we present proper information rather than just activity that actually helps the governing body and understand what's actually going on the ground. Is that okay?
I think it may be that occasionally we need to bring out a point around shifting volumes in the narrative rather than sort of layering in more metrics, because we have worked to get some clarity.
Exactly. Yeah. Okay, great. Thank you, John, for your work on that. Neil, finance report.
Thank you. Right. Okay. So there's a detail contained within the report. So I'll assume everybody's read through that, but I'll just pull out some key headlines to note. So the good news is year-to-date and forecast outturn is actually on plan. And if I take you to slide 10, page 93, which is the risk and mitigation table. The big change probably from what we presented at the last board is that we believe that we could mitigate the position should those risks materialise. And just to pick out some key assumptions that we put in there. So within the acute position, we've looked back at previous year's trends and we've now built that into the position. So you'll notice there's nothing on the right hand side of that table which is about any assumptions of acute performance going above what we've forecast in there. The QIP still remains a significant risk, and we still are assuming that over and above the current run rate that some of the QIP will deliver in the second half of the year. That was what we did plan on that anyway, so but it clearly remains a risk. The other issues are around things like the Meadbank nursing home, so that's still going on at the moment. We were aware of what some of the financial pressures were around those patients. I think around community services, it looks like with the values that we originally thought are not quite as high. So what we will do for next time is to have a look at whether or not the $500,000 that we've got in there is actually a real number, or whether actually we can mitigate that down a bit further. But I think the general message is we will be moving more now over from the right hand side of that table onto the left hand side and into the position. And based on what we're seeing today and noting those risks, we should be able to deliver the plan that we've set at the beginning of the year. I think in terms of in general with the rest of the position, it's not vastly different to what was reported last time to the board. So we are seeing acute pressures, in particular at Chelsea and Westminster Guy's, Kingston and St George's. The latter with St George's is more linked potentially to the QIP and the assumption that we'll actually start to deliver in the second half of the year. There are a number of challenges within the position that we're assuming will be delivered. We still haven't concluded the Q1 reconciliation yet, so until that is finally nailed down, that doesn't give us a level or a point from which we can be certain for the remainder of the year. But that is expected in the next couple of weeks. In terms of non-acute, we've now built in, there are some pressures around within mental health. So the mental health investment standard money now has all been utilised into the position. We have had some pressures around a risk share around PICU with South West London St George's. There is some still further conversation, but we've put into this position, and I think Wandsworth probably has been differentially impacted on that risk share across South West London, but we are having further discussions around that through to the end of the year, but that is built into our position. So I think it's the worst case we've got in here rather than the most likely at this stage, and AQP still remains the main area of significant concern around non-acute. In terms of primary care, reasonably stable from previous months, so nothing really has moved around the delegated commissioning. And if I could say with prescribing, we did have an issue around some of the pricing that we think was going to kick in from August. Further guidance has since come out, which seems to be suggesting that the impacts that we may have been expecting to see, and you will see within the risk table, actually may not materialise, and certainly not to the level that we've got in there. So that's actually a risk position that definitely is coming down. However, we still remain to see the numbers, but certainly the latest guidance suggested it's not going to be to the same extent. In terms of the QIP, I think most of the plans are pretty much on track, noting the points around the latter half of the year. The plan care transformation is the one QIP, and for all the reasons we've talked around RCT is probably the reason why that we have less confidence around that, but we have other mitigations that we built into the position to cover for that, and that still represents an opportunity running into 1920. So it's not that they've shelved, it's more about the timing of when they're likely to kick in. And then in terms of running costs, that's all on track, and the financial analysis, I don't think there was anything within that I would want to pick out. One final comment, which is not in the pack, but mindful that we've not really talked about, is around the underlying recurrent position, which is the key measure that NHS England will look at to really know what sort of financial health is the organisation in, and that's usually a good indicator if your recurrent position is showing a deficit, but you're obviously able to cover some of the pressures non-recurrently. At the moment, we do have, we are the right side of the line, we do have an underlying recurrent surplus running into next year. It's probably not as high as we would like it to be, and therefore it's about building that up through the QIP and getting as much headroom into the position that we can. But we are showing that it's at the moment it is a positive position on that. So I'm happy to take any questions.
Not so much a question, but just the table you show towards the end of the report on better payment practice data. I think the board should note with some pleasure the percentages that you're achieving now in terms of invoice numbers and values. I mean, these percentages would do credit to some Tim Pop dictatorship, being returned by 99.79%. And bearing in mind you did have some problems earlier in the financial year, I think this is a great credit to all involved, both in your department and elsewhere.
A dictatorship, right? I like that. My work is done.
I think what he means is, should we believe these figures?
I should probably just thank all directors and their teams, actually, because it's not something that can be delivered within finance. It's actually about the 7-day PO and receipting processes that everyone is having to comply with. So thank you to everyone.
The bits you can get right, you get right. That's a good start. Anything else anyone wants to talk about?
Well, we've got James here. I just wondered if he wanted to say anything about how this plays into the wider context of South West London.
Yeah, can do. Just late, but pick it up now. So we had our first finance committee in common last month, which was well attended. Had really good clinical representation, which was really welcome as well from all parties, and it covered all six. Covered all 6 CCGs, including Croydon, as well as all the CCGs in the Alliance, so that was good. We had quite a long discussion about the planning guidance and the impact potentially of MFF and how the allocations is playing out and how some of the tariff payments are going to change. So we went through some of that, and we can go through that in more detail when we know the whole picture, but it is going to cause some turbulence across, well, in everywhere, I suspect, but certainly there are some issues for London which we will need to play out. And I think we'll have to come up with how we manage that collectively across not just CCGs, but CCGs and providers along that. So that was a really helpful discussion to have, and we can pick up that in more detail in the local CCG. In terms of the system-wide position, we also had a conversation about how we're going to manage the system control total, and discussions we're ongoing with NHSE, which are not concluded yet, so we can't come to a conclusion on this yet, and Sarah and I were up there on Monday. But I think the main thrust of those was a recognition that system working is now, you know, the way we move forward. We know we've got some pressures at Sutton and Richmond that we are going to have to manage across the alliance, and we know that everybody's managing their own risks and mitigations across that. And we've looked at some options, one of which would include moving other CCGs looking to improve their position to offset that. But we're also looking with NHSE about how we can get some incentives in to do with that, and without getting into the detail, those discussions are still ongoing. I think some of the key messages that came out for me were, one is we need to make sure that there's consistency and there's an equal strength of challenge across all areas. So where CCGs are struggling, that they're seen to have done everything that they possibly can, and we know these things go in cycles and all that sort of thing. So, and I think that's not just about, you know, have they done everything that we can. I think it's also about how, as a system, we help them. So as well, not just in terms of money, but in terms of resources, and about how we use our management resources and some of our tools. And that's something that, again, we'll come on to over the coming months, no doubt. So I think there was issues around how to do that, and then there was issues about actually when other CCGs contribute in terms of increasing surplus, how do they gain access to that money in future, and what's the sort of risk pool arrangements. And we talked about how we need to refresh those, and again, those were part of the discussions that Sarah and I were having with NHSE. So at this stage, we're not, I don't think, unless things, we're not going to move any positions, and the forecasts will stay as they were for month 6, but we will keep people abreast of that, and we'll pick it up in the local finance committee this month with the Ones and Finance Committee. I don't know whether Chris wants to add anything about the Joint Finance Committee or anything.
Just one brief point. The dynamic of having all of the CCGs in the Alliance plus Croydon at a meeting is itself quite interesting, because your point about equal challenge did come up, and interestingly enough, it came up from Croydon. And as we all know, Croydon have actually masterminded a really significant turnaround in their financial position. So I think it's an interesting example of somebody who is called an organisation that has clearly had to make some very tough decisions to get to where they are now, and I think are quite reasonably saying, can we be satisfied that others are also having to go around that loop? So I think the dynamic of that's really quite interesting.
Yeah. And I think the sort of other dynamic I'd put to that, and this comes back to what my point about the management resources. Croydon's a big CCG. They've got a lot of management resource around that. If I look at other CCGs, particularly one who's struggling, they haven't got that level of resource. And that's not about giving people money or all that. It's about how we make sure we're using our resources in the right place. So that's something we need to think about over the coming months, about how we manage that. So it's a very valid challenge, and I think it asks other questions as well.
Okay, thank you, James. Katie?
I just wondered, given some of the risks that are set out in the report around sort of inter-CCG transfers of funding, obviously within South West London, the Finance Committee in Common will be really helpful at resolving some of those issues. I wondered about the ones outside of South West London, and whether you think the committee could have any influence on resolving some of those issues as well.
In terms of,
so we've got the Mead Bank one that is obviously from West London CCG.
Yeah, I mean, I think that's something we manage with South West London and with North West London across STP, so we can put pressure on that way. And the other one, the RHND, is another one that's a bugbear of mine, and Sarah and I have nagged again about that, because that affects Richmond as well. And David certainly has agreed a process by which we can get that resolved. So you're quite right. It's playing the influences in different places that we need to get to.
Okay, Good, thank you. Anything else on that report? Okay, so James, just kind of strayed into the next one really. So Sarah, do you want to do the Health and Care Partnership update, please?
So I was going to do two things, if that's okay. First of all, I was just going to give you an informal update. So, just on the, I had a lovely holiday as well, and I came back. I didn't see any camels. No camels actually in the Med, strangely. But I did come back actually a week earlier than you, Nicola, and went to a national meeting. So I thought I'd just give a bit of an update. So obviously we are still now awaiting the new forward view, which is the new 10-year planning that will come forward from our national teams within the NHS, and we have got some idea of what will be in those, and I think we are in the right place in South West London in that we are looking at system-wide at a kind of large-scale geography, but looking at locality, place being at borough level, looking at working across with providers in a different way, and really focusing on systems. So our local health and care plans will be key to that. We know that we'll have to have a new plan for the STP in the summer of next year, and our expectation is that it will be built on what we are doing now. We're not going to do something different in South West London. We have already gone through a process of refreshing our STP, and moving forwards what we will be doing is building on the local health and care plans into what we need to do for South West London. So I just wanted to give some assurance around that. The other things we are hearing, and we've mentioned some of them today, but we know that they're looking at allocations nationally, and those may well change. They're looking at different ways of managing the money across providers and commissioners, which will mean that the risk may well move around, and we definitely think there's some risk moving towards London, which is a problem for all of us. Looking differently about how we manage the money, so looking at system finances rather than commissioner and provider approaches, and trying to work together in order to reduce the amount we spend on our management costs and our administrative burden. And we absolutely, I think, can expect to get a management cost reduction coming towards us as part of that planning. So we will wait to see, but I'm sure that's going to come. So I just thought it was worth just highlighting. That was kind of my first week back. But what I would say is we're in a good place around our planning, because we are already progressing in South West London towards that direction. So we're going the right direction, we're doing the right things, we just need to keep going that way. So what you've got on your agenda here is the regular South West London Health and Care Partnership update. Can I say second iteration based on feedback? People wanted something shorter, so this is what you've got. We're happy to give further detail of other areas or more information, but we're kind of getting different views of what's required. However, I'm not going to go through the whole thing because I know you can read it, and we've already talked about some of the things in here, like the connecting care, but I wanted to pick two things out, in fact three. So one, the health and care plans I've already mentioned, but we are doing a lot of work locally on those, and they're really starting to motor forward. And I had a really good discussion with health and wellbeing chairs across South West London a week ago, and they were incredibly enthusiastic about the work that we are doing together, and wanting to have a really significant role in supporting us to deliver those. So that's the first thing. The second area that I would like to focus on is children and young people mental health. We together identified this as a priority long before they had identified it nationally as a priority across the whole of South West London. It's the only thing that I go and talk to people about in South West London. Everybody agrees this is the right thing to do. We want to do this together. So I just wanted to draw your attention to it because it's a fantastic piece of work we are doing across South West London. We have bid for additional funding through the National Trailblazer process for 3 boroughs, including Wandsworth, and we're really hopeful we're going to be successful, and we hope to hear soon. But we've also agreed across South West London to roll this out across South West London regardless. So even if we don't get Trailblazer money, or even if we don't get it for all of the boroughs, we're going to do it in all 6. So we are starting to progress that work, and I would encourage you to find out what's going on in this. It's a really positive piece of work. We had a presentation from Andrew Murray at our partnership board, which people were very enthused about and found very exciting for us going forwards. The other bit that I was going to bring your attention to was workforce. So we are starting to look at workforce across South West London and starting to think differently. So 2 of the areas that I thought thought actually this is really positive for South West London, is that we are looking at trying to make best use of the apprentices levy that we can access as South West London, and actually setting up a South West London Academy so that we can work with all providers to get the apprentices into South West London and support in a different way. The other thing I wanted to draw your attention to was the passport. So what we're saying is actually, and it's only for acute trusts at the moment, but it has been flagged to me that we might want to look at something similar for primary care. I'm not sure how we do this, but you know, we need to think about it. If you get your mandatory training in a acute trust in South West London, guess what? You can go and work at another acute trust without in South West London, not the whole, everywhere, but in South West London, you can go and work in another trust without having to redo all your mandatory training and get all your assessments done. That may sound totally straightforward. It has not been straightforward getting to that point, and actually makes a massive difference to staff. So what we are saying to staff in South West London is we want to retain you in South West London. We want you to work as part of the South West London family of the NHS, and we want to do everything we can to encourage you to stay in South West London. So if you want to be moving because of personal reasons, for whatever reason, we will encourage you to stay in South West London rather than go elsewhere. So that's just two of the things, but we are doing a lot more than that now in the workforce work stream. And it was challenged to me was what we're doing around primary care, because actually nurses in primary care, could we do something similar? I said that would be fantastic. I'm sure it's in, and I know what it's like working with 4 acute trusts. I don't know how we're going to do that with all general practice, but actually that should be our ambition and our aspiration. So what can we do more in this space as well for everybody? But I thought it was a really good piece of work to highlight. So I thought I'd highlight those 2 pieces, but happy to take questions. Carol.
I can't remember if this is included there, but there's been quite a bit of publicity in the past couple of weeks about some trusts paying the fee for their EU staff to get settled status. Yeah. Is that happening in South West London at any point?
So I think it's happening across London, and I think it probably, I couldn't tell you explicitly, but I think it probably is happening in South West London, particularly in places like Kingston, where they have a number of EU professionals and are very worried about Brexit. So I'm pretty sure we are. I couldn't tell you explicitly, but most London trusts are trying to support that in some way or another.
Can I do a follow-up? There's also a big problem with community care and care homes with these staff groups. Is there any possibility of anybody anywhere assisting with paying these fees for staff? Because just looking at care homes, there's a lot, and I know some of them quite well. There's a lot of EU staff in care homes. And
so it's going to be very difficult, I think, because local authorities are extremely stretched at the moment, and I think because care homes actually sit under the responsibility of local authorities, I'm not sure that local authorities would have the resource and the ability to be able to support that. And I'm sure local authorities would want to maybe have national discussions about that kind of thing rather than trying to fund locally. I think NHS trusts in London have some of them have taken that decision, based on the fact that actually it's cheap. They can't deliver their services otherwise. It is a slightly different position.
No, I cannot answer this, but I will take it back. Possibly it's something for London councils to consider across the whole of London, but certainly it's a very important point. Well, I've got to I can ask a question related to the health and social care plan. You might not be able to answer me yet, but given all the national push toward prevention and upstream, are we expecting any steps change in the way we work around prevention in the system?
So I think yes. So my view is, and I'm sure this will come out in the new forward view, and that's why I'm saying we're in the right place in South West London, because we are starting to develop the health and care plans, and we are focusing them around the joint strategic needs assessment and trying to focus on our areas of need and looking at the whole pathway, not just the delivery, if you see what I mean. So looking at prevention as well as, and all of the health and care plans that are being developed across South West London have quite big sections on prevention and support for people to remain independent and work in a different way. I'm hoping that when we get the forward view, there will be even more of a focus, and that will help us then to take the next step. But absolutely, I think it's recognised nationally that this is an area that we have maybe not progressed as well, as we should.
Perhaps just to give the context and just linking it back to some of the conversations we've been having around the plan, I think it's about what type of prevention we're talking about. I think that my sense is that quite often we are looking to intervene at an earlier stage of poor health, or just before something really becomes a sort of definably a medical condition, to prevent later things. So two good examples would be children and young people's mental health, where we know that we need to move interventions upstream to be able to deal with the growing burden of anxiety and depression and other mental health disorders, particularly amongst teenagers, and also diabetes, where increasingly the NHS is now trying to intervene in non-diabetic hypoglycemia, and also at the start of type 2 as well, to try and address people's lifestyles, rather than, because we know that we already spend about 9% of the budget dealing with the complications of type 2 diabetes at the moment. So I think that I'm not sure that my sense is that the NHS sort of overall plan will put a significant shift away from sort of NHS funded services into sort of primary prevention, which is where the local authority responsibilities are. But I think it's about within the spectrum of, and within the tiers of treatment within the NHS, trying to acknowledge that we need to move interventions sort of further upstream.
Okay. Any more on that, Katie?
So it was just to come back on the comments around primary care. So we absolutely have identified a number of the same workforce priorities that are referenced in this report, and I think we do have forums in place where we can review to see whether there's alignment of that across South West London. Yeah. So we can certainly pick that up and look at how we can work together to come up with a single solution.
Yeah, good, great, thank you very much. Thank you. Okay. Thank you, Sarah. So on to, so we've got summary minutes from two committees. One is the Integrated Governance and Quality Committee, and then the South West London Collaborative Decision Making Committee, which was in October, where we sent representatives to. So any comments or questions on any of those? Jamie?
Committees in common. If you look at the attendance list, you'll see no Health Watch reps. So apologies for that, but that's because we weren't invited. I'm one rep for Health Watch. The other is Adrian Attard from Sutton, and he wasn't invited either. So that's why we're not.
So I've had this in the other boroughs. So this is for the health and care plan deliberative event. That's
no, it's collaborative.
The committee in common.
And Health Watch wasn't there because they weren't invited.
Oh. Well, that's just an omission. I'm really sorry.
Okay.
So I don't understand why. So I'll find out what happened. I mean, I can see you're not in attendance, but I didn't know that you hadn't been.
So it's because it's constituted of 3 members from each board,
yes.
But then it would be only by accident if you were a member of one of the board.
We meant two Health Watch.
We meant for it to be separate to that. It's not within the.
Yes, we do have 2 Health Watch reps as part of the formal governance. So in attendance, not but yeah. So let me go back and find out, because I don't know what that's happened. I apologise.
Okay, thank you, Jamie, for raising that. Anything else on those summary minutes? No, thank you. And we have any other business. Does anybody, Malik or Sean, would you like to ask any questions or make any comments to the board? No? Thank you. Thank you for coming. Jolly good. So we've got a part 2 now, but shall we just have a quick comfort break before we launch into that? So let's just take 5 minutes. Thank you very much, everybody, for that part of the meeting.